Hello everyone, welcome to Yellow Pages Nursing. In today's video, we will be discussing about a very important topic, diabetic ketoacidosis. It's a very significant topic, and to make you more clear, we have explained in very simple and easy terms, so please do not skip and do watch the entire video. Before entering into the session, if you have not subscribed our channel, please subscribe our channel and do not forget to hit the bell icon to receive instant notifications. Let's get into the topic. Well, before looking into diabetic ketoacidosis, let's brief about diabetes mellitus. Diabetes mellitus is a group of metabolic diseases characterized by elevated levels of glucose in the blood, that is hyperglycemia, resulting from defects in insulin secretion or insulin action or both. As we all know, insulin is a hormone which is produced by the pancreas. It controls the level of glucose in the blood and regulates the production and storage of glucose. Now what happens in the diabetic state is either the cells may stop responding to insulin or the pancreas may stop producing insulin entirely. And this leads to hyperglycemia, which may result in acute metabolic complications such as diabetic ketoacidosis, that is DKA, and hyperglycemic hyperosmolar non-ketotic syndrome, that is HHNS. Now, diabetic ketoacidosis. Diabetic ketoacidosis is a serious life-threatening complication of diabetes. Diabetic ketoacidosis is most common among people with type 1 diabetes. People with type 2 diabetes can also develop DKA. The main reason why diabetic ketoacidosis develops is when the body doesn't have enough insulin to allow blood sugar into cells for use as energy. Diabetic ketoacidosis, in short, is called as DKA, is characterized by hyperglycemia, ketonemia, and acidemia. And this results from disorders in the metabolism of carbohydrate, protein, and fat. Next, let's look into the causes of diabetic ketoacidosis. First comes illness. Any illness may lead to stress. Sometimes, being sick can cause the body to release higher amounts of certain hormones like stress hormones, for example cortisol and adrenaline. These hormones make it more difficult for the body to use insulin properly. Next causes infections like pancreatitis, pneumonia, bacteremia, UTI, etc. Now, just like with illness, infections also causes the body to release certain hormones that makes it harder to use insulin. Oftentimes, if there is diabetes and an infection, the body needs more insulin than usual. Next causes ischemia or infarction such as acute coronary syndrome, critical limb ischemia or ischemic bowel, and heart attack or stroke. Next causes drug intoxication, for example ethyl alcohol, cocaine, methamphetamine, etc., which can also trigger diabetic ketoacidosis. Next cause may be lack of insulin, for example missed dose. Next cause is iatrogenic, which may be secondary due to some medications like antipsychotic drugs and corticosteroids, and also due to surgeries. Next cause is in pregnancy. As pregnancy progresses, mother may require more insulin, which could also trigger diabetic ketoacidosis. Next, let's get into the pathophysiology of diabetic ketoacidosis. Before that, first you should know about the function of insulin so that you will have a clear idea about the pathophysiology. Pancreas makes insulin and releases it into the bloodstream. Insulin helps to move glucose into the cells. Now, cells use this glucose for energy, and the body stores any extra glucose in the liver, muscles, and fat cells. The major function of insulin includes increased glucose uptake by liver, skeletal muscles, and adipose tissue. So, in the liver, this glucose uptake enhances glycogenesis, that is, formation of glycogen, and in the muscle, it enhances protein synthesis, and in adipose tissue, it enhances adipogenesis, that is, formation of adipocyte, that is, fat cells. Remember that this is the normal function of insulin. But what happens in diabetic ketoacidosis is there is lack of insulin, which enhances glyconeogenesis, that is, formation of glycogen from non-carbohydrate sources, which in turn leads to hyperglycemia. In muscles, it enhances glyconeogenesis, and in adipose tissue, it enhances lipolysis, which is nothing but breakdown of fat cells, and also leads to formation of ketone bodies. So, looking into the pathophysiology of diabetic ketoacidosis, without insulin, the amount of glucose entering the cells is reduced and the liver increases glucose production. This leads to hyperglycemia. So, in an attempt to get rid of the body's excess glucose, the kidneys excrete the glucose along with water and electrolytes, for example, sodium and potassium. This osmotic diuresis is characterized by excessive urination, that is polyuria, which leads to dehydration and marked electrolyte loss. The other effects of insulin deficiency is breakdown of fat into free fatty acids and glycerol, which leads to free fatty acids getting converted to ketone bodies by the liver and leading to accumulation of ketone bodies in the circulation, which finally leads to metabolic acidosis. Now, let's look into the signs and symptoms. Polyuria, as we know, frequent urination. Polydipsia, that is frequent thirst. Enuresis, that is involuntary urination. Dehydration, causing tachycardia, that is increased heart rate, and orthostasis. Abdominal pain, causing nausea and vomiting. Fruity breath odor or acetone odor breath. Next is Kussmaul breathing. Here, a low partial pressure of carbon dioxide, that is 10 to 30 mmHg, reflects respiratory compensation, that is Kussmaul respiration, for the metabolic acidosis. Next comes mental status changes such as combative, where they are ready or eager to fight or argue, stupor, coma. Next, let's discuss about diagnostic evaluation of diabetic ketoacidosis. First is history collection. Here we collect informations like patient is taking steroids or antipsychotic drugs, any presence of illness, infection or ischemia, drug abuse, and any surgical history. Next comes physical examination, where we see signs of dehydration like dry mucous membrane, poor skin turgor, Kussmaul respiration, acetone breath or a fruity odor breath. Next comes blood investigations, where there is hyperglycemia, that is blood level glucose is 300 to 400 mg per dl. Electrolyte imbalance, for example, sodium, potassium, which is caused because of osmotic diuresis, and ketone bodies are found in the blood, and elevated blood urea nitrogen and creatinine. In ABG, there is decreased pH, decreased level of bicarbonate, and decreased level of partial pressure of carbon dioxide, and anion gap is more than 10. In urine, there is presence of ketone bodies and infections, which is indicated by presence of pus cells. Next, let's look into management of diabetic ketoacidosis. The important things to be done here are correction of shock and dehydration, correction of hyperglycemia, correction of deficits in electrolytes, correction of acidosis, and treatment of infection. The priorities in the management are circulation, airway, and breathing. And after stabilizing all of this, we get into controlling hyperglycemia, which is done by insulin administration, either by bolus or continuous infusion. Here, insulin 0.1 unit per kg IV bolus initially is given, followed by continuous IV infusion of 0.1 unit per kg per hour in 0.9% saline solutions. And insulin should be withheld until serum potassium is more than or equal to 3.3 milliequivalent per liter. The very important and main management is rehydration. Usually, patients may need up to 6 to 10 liters of IV fluid to replace fluid losses caused by polyuria, hyperventilation, diarrhea, and vomiting. Next is initial bolus of isotonic saline followed by hypotonic saline solution as long as the patient is hemodynamically stable. The examples are sodium chloride 0.9% or 0.45%. Plasma expanders may be necessary to correct severe hypotension that does not respond to IV fluid treatment. Now the next main management is restoring electrolytes, that is potassium correction. Monitor serum potassium every 6th hourly, where we have to closely monitor for arrhythmias too. And other electrolyte deficits should also be correlated. Next management is reversing acidosis. Ketone bodies accumulate as a result of fat breakdown. The acidosis that occur in diabetic ketoacidosis is reversed with insulin, which inhibits fat breakdown, thereby stopping acid buildup. Insulin is usually infused intravenously at a slow, continuous rate, for example, 5 units per hour. And bicarbonate infusion is also given for treating metabolic acidosis. Now, here comes nursing management of diabetic ketoacidosis. Monitor vital signs and neurological status. Monitor the SpO2 level every hourly. Maintain intake-output chart every hourly. Monitor for the signs of fluid overload. Monitor the blood sugar every hourly. Monitor the serum electrolytes level. Monitor for arrhythmias, especially during potassium infusion. And monitor ABG. The important nursing diagnoses for diabetic ketoacidosis include risk for fluid volume deficit related to risk factors like decreased intake of fluids, gastric losses due to nausea and vomiting, hyperglycemia-induced osmotic diuresis. So here you go with diabetic ketoacidosis. If you find this video useful, please like it, subscribe it, share it, and do not forget to hit the bell icon to receive instant notifications. Thanks for watching and have a nice day.